Blood in a healthy heart is a high-velocity fluid, but when ventricular function declines, that fluid dynamic breaks down. Red blood cells pool, platelets aggregate, and a dense gelatinous mesh begins to form in the stagnant zones. Consider the case of a 65-year-old male diagnosed with chronic heart failure with reduced ejection fraction, or HFrEF. His left ventricle was heavily remodeled, featuring an apical aneurysm that severely compromised normal blood flow. Routine imaging identified a left ventricular thrombus. To prevent systemic embolization, the patient was prescribed a therapeutic dose of apixaban, 5 mg twice daily. This is a transthoracic echocardiogram taken 6 months into that treatment plan. Right here in the left ventricular apex, we can see a clear 0.7 by 2 cm echolucency. The apical thrombus is still present, completely resisting half a year of therapeutic anticoagulation. For those entire 6 months, the patient remained entirely asymptomatic. There were no strokes, no focal neurologic deficits, and no outward signs that a potentially lethal clot was occupying the akinetic wall of his heart. Standard American College of Cardiology and American Heart Association recommendations suggest a 3-month course of anticoagulation for a left ventricular thrombus, followed by expected resolution. Those guidelines largely rely on data from patients recovering from an acute ST segment elevation myocardial infarction. They assume the heart muscle will heal and normal flow will eventually resume. Chronic HFrEF presents a different mechanical environment than the acute cases that shaped current guidelines. When the ventricle is permanently remodeled, a fixed 3-month clock fails to account for the actual biology at work. To understand why treatment failed, look at how the thrombus was tracked. This is the unenhanced echocardiogram. The apical region is severely obscured. Unenhanced scans frequently lack acoustic clarity. The endocardial borders blur, making it impossible to definitively confirm an apical clot. To rescue the diagnostic yield, clinicians administer a lipid contrast agent, commonly known as Definity. Here is the contrast-enhanced scan. The microspheres flood the chamber, sharply delineating the endocardial borders and exposing the dark, 0.7 by 2 cm thrombus hidden against the wall. Without this contrast fluid outlining the mass, establishing an accurate baseline size and morphological profile is impossible. When poor imaging obscures these details, clinicians risk prematurely stopping therapy based on a false assumption that the clot has resolved. For chronic HFrEF patients with suspected apical remodeling, relying on unenhanced scans is a liability. Contrast-enhanced echocardiography, or cardiac MRI, is strictly required to establish the true thromboembolic baseline. The physical environment of the ventricle dictates how well a drug can work. An acute post-STEMI thrombus forms during a temporary period of cardiac shock. In a STEMI, myocardial stunning recovers, restoring blood flow. But an apical aneurysm creates a permanent structural pocket of hemodynamic stasis. This dead space continuously drives platelet aggregation and fibrin formation, regardless of how much time passes. Direct oral anticoagulants counteract this process. They offer a broad therapeutic index, but they also have notably short pharmacokinetic half-lives. This chart shows inconsistent medication adherence. When a patient misses doses, apixaban blood concentration plummets below the therapeutic threshold. Each missed pill opens a window of vulnerability, allowing the clot to persist and grow. A direct oral anticoagulant only works if the patient's adherence outpaces the ventricle's permanent mechanical drive to clot. If adherence falters, the therapy is neutralized. Moving past this single case, the broader clinical data points to a clear need for a formal risk stratification matrix. This matrix visualizes the physical characteristics predicting treatment resistance. Looking at thrombus characteristics, larger baseline volume predicts a slower resolution rate. However, morphology presents a paradox. Mobile, protuberant thrombi carry a high immediate risk of ischemic stroke compared to flat clots. However, that same dangerous protrusion increases the clot's surface area. This exposes it more effectively to fibrinolysis and anticoagulant agents, often resulting in faster resolution. Looking strictly at the overall left ventricular ejection fraction fails to capture the full structural risk. Expanding end diastolic and end systolic diameters strongly correlate with clots that refuse to dissolve, pointing to severely impaired mechanical flow. The duration of anticoagulant therapy cannot be decided by a standard 3-month calendar. It must be determined by assessing the specific thrombus morphology against the severity of the patient's ventricular remodeling. Left ventricular thrombus persistence in chronic HFrEF is an expected complication when severe structural remodeling meets imperfect medication adherence. Standard 3-month regimens fail to address the realities of these high-risk profiles. Extended or even indefinite anticoagulation may be necessary, and that duration must be strictly guided by serial contrast imaging or cardiac MRI. To address variability in how clinicians interpret images, research is moving toward AI-assisted quantification. Future workflows will feed contrast-enhanced imaging directly into automated analysis. These models standardize acquisition and objectively calculate thrombus burden and mobility, providing consistent metrics for high-risk features. Simultaneously, pharmacogenomic profiling decodes variability in drug metabolism, allowing clinicians to predict a patient's response to an anticoagulant before the first pill is swallowed. By combining automated morphological data with polygenic risk scores, the pathway produces a highly precise, individualized anticoagulation strategy. Understanding why treatments fail in chronic heart failure provides the roadmap for a more specific approach, one where the duration of therapy is decided by the patient's individual risk profile rather than a generic calendar.